Hi, glad you could join me for our series on C. diff colitis. This video is part 3 in our 4-part series, and today we will be discussing C. diff diagnosis and treatment. In part 1, we introduced what C. diff actually is and discussed asymptomatic colonization and C. diff's role in the environment. In part 2, we discussed who is at risk, which is anybody that takes antibiotics, and steps for prevention, which is maintaining a normal microbiome. In this video, let's get into how we diagnose and treat C. diff. I'm Dr. Katrina Coulter. I'm an infectious disease physician, and I make educational health videos with a focus on the microbiome. This video is for information purposes only and not to be taken as medical advice, but I really want you to have this information to empower you. So let's get into diagnosis of Clostridium difficile infection. The first and foremost important thing when diagnosing this infection is to test the right person. We should never test somebody that is not having diarrhea. And that's because the test results can be difficult to interpret and don't distinguish between colonization and infection. And that's why on part 1, we went over the importance of understanding that colonization with C. diff is normal and that it is all over in our environment. Anyone that is colonized should not be treated, but somebody with active infection should be. So we only test persons that are having active diarrhea, and the test needs to be done on a liquid stool. It needs to be pourable. Now, there are 3 types of tests that can be done routinely on stool. There is a toxin test, which is going to test for the presence of toxins in the stool. There is a PCR test, also called a nucleic acid amplification test, and that just tests for the presence of toxigenic C. diff in the stool. And there is also an antigen test called a glutamate dehydrogenase test, and this tests for an antigen that is made by all strains of C. diff, toxigenic and non-toxigenic. So when we as healthcare providers look at tests, we consider if they're sensitive or specific. A sensitive test means it is very good at ruling something in. So it's going to catch most of the positives. A specific test is something that is really good at ruling something out. So if it's not there, if it's negative, it's not there. The problem with a sensitive test is that sometimes you'll catch things that aren't really there. That's called a false positive. And the problem with a specific test is sometimes you'll rule out something that really is. So you'll have a false negative. So you want a test that's going to be sensitive and specific, but not get too many false positives or too many false negatives. So each of these tests that I've talked about have different levels of sensitivity and specificity. And really going into that, I feel like is too much for the scope of this video. But the main takeaway is that because these tests don't always distinguish between an asymptomatic colonization versus active infection, you need 2 tests at a time. So that either means you need a positive PCR test and a positive toxin test, or you need a positive antigen test and a positive toxin test to rule in the diagnosis. Now, the PCR test will test for toxigenic strains of C. diff, but you can be colonized with a toxigenic strain and not have active diarrhea. However, if you are colonized with a non-toxigenic strain, this test will be negative and we will know, hey, it's just colonization. Now, the toxin test is usually going to be positive in somebody that actually has a C. diff infection because they are going to have active toxin in their stools. But the weakness of this test is that it's not very sensitive. It's only about 80% sensitive, so it doesn't pick up all the positive toxins. And if a stool is left at room temperature for more than an hour, the toxins start to degrade, making this test less sensitive. So what I'm saying is, just because your toxin test is negative does not mean that you do not have C. diff. It just means that it might not have been a good sample, or it may mean that it just didn't pick it up. Also, another weakness of this test is patients can have toxin in their stool and not have diarrhea. That is why we should absolutely only test on patients that are having diarrhea. Now, that last test I mentioned, the antigen test, is very sensitive and very specific, but it is present in all strains of C. diff. And so you may have colonization with a non-toxigenic strain of C. diff, and that test will be positive. And you may be having diarrhea, but it may be due to something else, like norovirus, and that test may be positive, and that does not help you know if your diarrhea is due to C. diff or not. And so that's why we always use two tests in our algorithm to try to determine, okay, if this is present, then is it a toxigenic one or a non-toxigenic one? And then make our interpretation based on that. So say we have a positive in AAT or a PCR test, and we have a positive toxygen test, and our patient has diarrhea. So we feel pretty confident that they have C. diff. What is the next step? Well, first, we want to minimize systemic antibiotics if possible. So if that patient is receiving antibiotics at that time and they can be stopped, they should be stopped. If they cannot be stopped, we kind of work through that. The second is we typically treat with another antibiotic. Now, this video is being made during the first half of 2026. So this information is accurate as of now, but I do expect this will change over time because through my career, the treatment has changed. When I first started as an infectious disease doctor, the first line of recommended treatment was an antibiotic called metronidazole, also known as Flagyl. Now that is not in our treatment algorithm. So as we've gotten better antibiotics and more evidence, we update what we treat it with. So metronidazole is out. That is not a first-line treatment. So now our first-line treatment is something called fidaxomicin. This is relatively new. This is an update that just happened in the past couple years, and so we also see treatment with another commonly used antibiotic, oral vancomycin. It must be oral. This antibiotic also comes in an intravenous format, which will not treat C. diff. It has to go in through your mouth. So we have fidaxomicin as now our Infectious Disease Society Association recommended first-line treatment, and we have oral vancomycin as kind of our second-line treatment, but still frequently used in clinical practice as a first-line treatment and still quite effective. So we treat our infectious diarrhea caused by antibiotics with yet another antibiotic. Treatment duration for the fidaxomicin, also called difficile, is 10 days, and oral vancomycin treatment is usually 10 to 14 days. This is for a first episode of C. diff, and that's what we're discussing in this video. Now, I do want to introduce something that we commonly do for recurrent episodes of C. diff. We will go more into recurrent C. diff in our fourth video. But we do have something called a fecal microbiota transplant. That is when you take the healthy stool of another patient and transplant it into a patient with active or relapsed Clostridium difficile infection. I know this sounds weird and maybe disgusting, but it works really, really well. And so this can either be done with a nasogastric tube that goes into the nose and takes it down into the upper part of the small intestine, or it can be done by an enema or a colonoscopy, which is the most effective, or it can be done by a pill. And as of 2026, the two common methods to do a fecal microbiota transplant are by either an enema or by a pill. That is what is currently available on the market. And so these are our treatment options and our diagnostic techniques as of the first half of 2026. And now you know all there is to know. So please stay tuned for my last video. Part 4 is going to be on recurrent C. diff and what this looks like and what can be done about it. So stay tuned. Make sure you subscribe so you don't miss it. I'll see you on the next video.